If a doctor recently looked at your chart, smiled, and said your blood pressure is perfect, I want you to hold onto that feeling for one more minute. And then let me show you something that most 15-minute appointments never have time to cover. Because for a meaningful number of adults over 70, the exact number that makes a chart look great on paper can be the same number that makes a person feel dizzy standing up at 3 a.m., reaching for a wall that isn't quite where they remember it. I'm going to walk you through the research behind this, why an aging cardiovascular system doesn't behave like a 50-year-old's, and a simple 3-minute test you can do tonight with a $20 home monitor. B. By the end, you'll understand your numbers, or your parents' numbers, in a way that goes well beyond lower is always better. This isn't a fringe idea. It's a conversation already happening inside cardiology and geriatric medicine, in journal articles and specialist conferences, even as the advice most people hear in a routine 15-minute visit hasn't fully caught up yet. That gap between where the newest research points and what actually gets communicated at the average appointment is exactly what I want to close today. Stick with me, because the difference between understanding this and not understanding it can be the difference between staying steady on your feet and ending up on the floor of your own kitchen. Let me start with a story, because numbers only mean something once you see what they do to a real life. Eleanor was 78. She played bridge every Thursday, kept her own garden, and drove herself everywhere, including every single Sunday, to see her grandchildren across town. She'd had high blood pressure for over a decade, managed carefully by her doctor with a steady succession of medications. Every few months, another small adjustment. Every adjustment brought her closer to the number her doctor had learned to chase, 120/80. When she finally got there, her chart reflected exactly what it was supposed to. Excellent control. 4 months later, she stood up from her recliner to answer the phone, and the room simply wasn't there anymore. She woke up on the floor with a fractured hip. In the ambulance, paramedics took her blood pressure lying down. It was fine. Standing, moments earlier, it had. Her son asked her cardiologist a question that deserves a real answer. How can a perfect number cause this? That question is really the heart of everything I want to explain today. And Eleanor's situation is not rare or unusual. Falls are one of the leading causes of injury-related hospital visits among older adults, and a growing body of research suggests that overly aggressive blood pressure control is a meaningful, under-recognized contributor to some of those falls. It rarely shows up as a headline. It shows up quietly, one dizzy spell at a time, often dismissed as just getting older until something finally breaks. For most of my career, the guidance for treating blood pressure has been refreshingly simple. Lower is better, and 120/80 is thighs, a gold standard to aim for. And for adults in their 40s, 50s, even many in their 60s, that guidance holds up extremely well. It's backed by decades of solid evidence, and I still recommend it for that population without hesitation. But something changes in the body as it ages, and the research that built the modern blood pressure targets wasn't necessarily designed with that changed body in mind. To understand why, we need to look closely at where those targets actually came from. In 2015, a major U.S. study called the SPRINT trial enrolled more than 9,000 adults over the age of 50 to compare two blood pressure strategies: an intensive target under 120 systolic versus a standard target under 140. The results made headlines everywhere. Fewer heart attacks, fewer strokes, fewer cardiovascular deaths in the intensive group. It reshaped how doctors across the country approach treatment, and it's a big part of why 120/80 became the number so many patients now have memorized. Here's the part that got far less attention. SPRINT deliberately excluded people with diabetes, people with a prior stroke, people with dementia, people with advanced kidney disease, and people who were already frail. In other words, the trial proved that aggressive targets help a specific, relatively healthy subset of older adults, not the average person in their late 70s managing 3 chronic conditions on 4 different medications. Not, in all likelihood, Eleanor. And within that same trial, the intensive group experienced meaningfully higher rates of fainting, dizziness, kidney complications, and falls requiring hospital treatment. The cardiovascular benefit was real, so was the cost. A separate study out of China in 2021, the STEP trial, followed more than 8,000 adults aged 60/80 and found nearly the same pattern. Better cardiovascular numbers in the intensive treatment group, alongside more falls, more dizziness, and more strain on the kidneys. Neither of these studies is wrong. They answered an important question well, and they genuinely advanced how we treat blood pressure in a specific, healthier slice of the older population. The problem is what happened next. The answer got generalized far beyond the group it was tested on, applied broadly to patients who, on paper, would never have qualified for the study that produced the target in the first place. That gap between the research population and the person actually sitting in the exam room is exactly where people like Eleanor fall through, sometimes literally. Think about what that means in practice. A trial builds its conclusions from the people it enrolls. If the healthiest, most robust, older adults in that trial do well on an aggressive target, the honest conclusion is an aggressive target works well for people like them. It is not automatically true for someone with 3 chronic conditions, 5 medications, and a kidney function that's already declining. But guidelines, once written, tend to get applied as a blanket rule rather than a conditional one, and patients rarely know to ask which category they actually fall into. So why does age change the equation so much? 3 things are happening inside the cardiovascular system that don't show up on a resting blood pressure reading. The first is arterial stiffness. Think about a garden hose that spent 20 years coiled up outside versus one fresh off the shelf. Teehee old hose doesn't flex the way it used to. Arteries undergo something similar over decades. They lose elasticity and become less able to absorb the pressure wave with each heartbeat. A slightly higher baseline, pressure becomes necessary just to reliably push blood up to the brain, especially the moment you stand upright against gravity. The second is a change in something called baroreceptor sensitivity. Tiny pressure sensors embedded in the blood vessels that detect drops in pressure and immediately signal the heart to compensate. In a younger person, this reflex kicks in within milliseconds of standing. In an older person, that reflex often slows down significantly. If someone's baseline pressure is already tightly controlled at 120 and their baroreceptors are sluggish, a sudden drop on standing can reach the brain before the body has time to correct for it. That's the room spinning sensation. That's the moment Eleanor's living room disappeared. The third factor is medication metabolism. Kidneys and liver process medications differently at 75 than they did at 50. A dose that was calibrated correctly 5 years ago may now be hitting harder and lasting longer than intended, quietly pushing blood pressure lower than a single office reading would ever reveal. A sitting reading, OF 122 over 76, can look flawless on a chart. It tells you nothing about what happens the moment that same person stands up. There's a fourth factor worth mentioning too, one that compounds all 3 of the others. Dehydration and reduced fluid intake, which become more common with age as thirst signals, themselves grow less reliable. A person who drinks less water than they used to, on top of a stiffer vascular system, slower reflexes, and a medication dose that's stronger than ever intended, is stacking several small vulnerabilities on top of each other. None of them alone might cause a fall. Together, they often do. Put all 4 of these together, and you can see why a single-seated blood pressure reading in a doctor's office is really only half the picture. It captures a calm, resting moment in a controlled position. It doesn't capture the physical stress of standing up out of a chair after a big meal, or getting out of bed in the middle of the night, or climbing out of a warm bath. Exactly the situations where a fall is most likely to happen. Which brings me to something almost anyone can do tonight, with no appointment required. All you need is a home blood pressure monitor. Inexpensive, available at any pharmacy. Lie down flat and rest quietly for a full 5 minutes. Take a reading, write it down. Then stand up immediately and take a second reading right away. Not after a minute, not after you've steadied yourself immediately. Write that number down too. If the top number, the systolic, drops by more than 20 points when you stand, or the bottom number, the diastolic, drops by more than 10 points, that's a recognized condition called orthostatic hypotension. It is measurable, it is common in older adults, and it is very often related to medication dosing, which means it's something a doctor can actually act on if they have the data in front of them. This is a test that rarely gets performed at a routine visit, mostly because a single-seated reading in the office is faster, but it takes 3 minutes at home and it can catch exactly what a chart alone cannot. If you get numbers like this, don't file them away. Bring them to your next appointment, ideally alongside a log of home readings taken morning and evening over a week or 2, and a plain list of any symptoms: lightheadedness on standing, unexplained fatigue, morning brain fog. These are not simply things to expect with age. In someone on blood pressure medication, they can be a signal that the target on the chart doesn't match what that person's body actually needs. Now, I want to be very clear about something before I go further, because this is the part where a video like this can do real harm if it's misunderstood. None of what follows is a set of numbers to self-prescribe. Blood pressure targets for older adults genuinely do vary by age, frailty, kidney function, and other conditions. That part of the research is well established, and several medical societies have already moved toward more individualized, less one-size-fits-all guidance for adults over 65. But translating that into your own personal target is a conversation to have with your own physician, with your own labs and history in front of them, not a number to adopt from a video, and act on alone. Never stop or adjust a blood pressure medication without your doctor's involvement. Sudden changes can be dangerous in their own right. With that said, here's the general shape the current research points toward, so you know what kind of conversation to start. For adults in their 60s and early 70s who are active, independent, and not managing multiple chronic conditions, A somewhat lower systolic target is often well supported and appropriate. This is closer to the population that trials like SPRINT actually studied. For adults in that same age range who also have diabetes, a prior stroke, several medications, or any pattern of dizziness on standing, many geriatric and cardiology specialists now favor a more moderate target rather than chasing the lowest possible number, because the fall risk can outweigh the marginal cardiovascular benefit. For adults in their late 70s and 80s who are otherwise healthy, a number of studies now suggest that outcomes are often best in a moderate range, rather than at the most aggressive end of the scale. And for adults who are 85 or older, or frail at any age, preventing a fall is frequently a higher clinical priority than hitting an aggressive number at all. There's also a number that gets far less attention than it should: the diastolic, the bottom reading. In older adults, a diastolic pressure that drops below 60 can compromise blood flow to the heart muscle itself during its relaxation phase, even when the systolic number looks perfectly fine. If your diastolic is consistently under 60, that's worth flagging at your next visit regardless of how the top number looks. It's also worth saying clearly, none of these ranges are a substitute for an Act 2 AL diagnosis or an actual treatment plan. They're meant to give you a rough sense of why one target fits everyone, doesn't hold up well past a certain age, and to help you recognize whether your own situation might benefit from a more individualized conversation. Two people with identical readings can have completely different underlying risk profiles, and a good clinician weighs all of it together, not just the number on the cuff. Let me give you two more brief examples, because the same reading can mean two very different things in two different people. Walter is 73. He still plays tennis twice a week, has no diabetes, no history of heart attack or stroke, and strong kidney function. His blood pressure runs around 142 over 84, and he feels completely fine. His doctor was considering adding a second medication to bring him closer to 120. In a case like Walter's, many specialists would now say, proceed cautiously, or possibly not at all. The risk of pushing an otherwise healthy, active person into orthostatic territory may outweigh the marginal benefit of chasing a lower number. Walter is still playing tennis. Now take Marjorie, also 73, with the exact same reading, 142 over 84. But Marjorie has type 2 diabetes, a prior cardiac event, and reduced kidney function. For her, that same 142 over 84 does carry real risk, and lowering it is reasonable. But the goal isn't 120 either. It's a more moderate target, reached gradually with orthostatic checks built into every dose adjustment along the way. Same starting number, two very different plans, because good medicine treats the person, not the chart. That's really the whole idea in one sentence. The same reading can call for two different responses depending on age, frailty, kidney function, other conditions, and how the body actually responds when it stands up. A number in isolation doesn't tell a doctor enough. A number combined with a fall history, a medication list, and an orthostatic check tells them almost everything they need. One more example, because I think it's the one people relate to most. Frank is 81, lives alone, and has mild kidney disease along with a pacemaker placed a few years back. His blood pressure sits around 148 over 82. On a standard chart, that reading might trigger an automatic push toward Medicaid's on changes. But Frank had two falls last winter, both after standing up too quickly, and his orthostatic check at home showed a 24-point drop on standing. For someone in Frank's position, older, living alone with a documented fall pattern, most geriatric specialists today would treat fall prevention as the more urgent priority and would be cautious about lowering his pressure further, even though the number looks high by younger adult standards. The math is completely different when a fall could mean lying on the floor alone for hours before anyone finds you. This is why I keep coming back to the same point. A number by itself, stripped of context, can mislead a doctor just as easily as it can reassure one. The people who get the safest, most appropriate care are usually the ones who show up with a fuller picture. Home readings, an orthostatic check, a symptom list, and a living situation their doctor actually knows about. So if you already have a blood pressure target from your doctor, I'm not suggesting you throw it out or adjust anything on your own. I'm suggesting you bring more information to the conversation than a single office reading usually provides. Bring 2 weeks of home readings, morning and evening. Bring the results of the standing and lying test from tonight. Bring an honest list of any dizziness, fatigue, or fogginess you've noticed. Then ask directly, given my age, my conditions, and the medications I'm on, is this specific target still the right one for my body? A physician who's current on this research will take that conversation seriously, and the data you bring is exactly what makes that conversation productive instead of vague. Eleanor's son once asked why this kind of nuance isn't just standard practice everywhere, for every patient over 70. The honest answer is that medical guidelines move slowly by design. They need large trials, replication, and consensus before they officially shift. And that process takes years, even after the underlying research starts pointing in a new direction. In the meantime, a lot of individual physicians are already having exactly this kind of nuanced conversation with their patients. It just doesn't always fit neatly into a 15-minute visit unless the patient brings the data that prompts it. After Eleanor's fall, her care team took a second look at her medication list. 2 of her 3 blood pressure drugs were reduced, her pressure settled at a more moderate level than the original target, and her orthostatic drop shrank from over 30 points down to about 10. Some months later, she mentioned, almost in passing, that she'd started driving to see her grandchildren again on Sundays. That's really what the right number looks like in practice. Not a number that satisfies a guideline written for a different population. A number that lets someone stand up in their own kitchen without the floor moving. If there's one thing worth taking away from all of this, it's that blood pressure targets for older adults are not one size fits all, and the landmark studies that shape today's default targets specifically excluded many of the patients those targets now get applied to. A body at 75 doesn't move blood the same way a body at 50 does. Stiffer arteries, slower reflexes, different medication handling, and often less reliable hydration all change the calculation. A simple lying down then standing up check at home can reveal something a single office reading never will. And the right target for any individual has to come from a real conversation with a real physician who knows that person's full picture. Not from a video, and not from a guideline built for someone else's body. I also want to leave you with this. None of this is a reason to distrust your doctor, or to assume every clinician is behind on the research. Many are already having exactly this conversation, adjusting targets carefully for their older patients and taking fall risk. Seriously. What this is a reason to be an active participant in your own care rather than a passive recipient of a single number. Bring data, ask questions. Notice your own symptoms instead of writing them off as an inevitable part of aging. A good physician will welcome that because it makes their job easier, not harder. Think back to Eleanor for a moment. The version of her that existed before the fall, gardening, playing bridge, driving across town every Sunday, wasn't lost because her heart was failing. It was nearly lost because a target built for a different population got applied to her without anyone checking what happened when she stood up. The version of her that exists now, driving to see her grandchildren again, exists because somebody finally asked the right question and looked at the fuller picture instead of just the chart. That's really what know your real number means in practice. It isn't a fixed number I can hand you in a video. It's a process. Checking your pressure lying down and standing up, tracking it over time, noticing your own symptoms, and bringing all of that into a real conversation with the person who manages your care. If this changed the way you think about a number on a chart, the most useful thing you can do with it is simple. Check it tonight, write down what you find, and bring it to your doctor. That conversation, grounded in your own data rather than someone else's average, is where the real protection comes from.